If you have shaky hands or you were diagnosed with essential tremor, this is the video to watch. We are going to talk about, number one, the importance of this topic and what we can do about it in 2025. So let's start defining essential tremor. Many years ago, we used to call this problem benign familial tremor. There is nothing benign about this condition, and not always is familiar. There are many patients that they don't have any family history of tremors. The word essential in medical terms means that we don't know the cause. Other words that we use is idiopathic. It's a fancy word to tell you I don't know why this is happening. We know that most likely is related to a problem in one part of the brain, which is the cerebellum, the back of the head. Why we know that? Because when you do autopsy in patients with essential tremor, you find abnormalities in that particular area, some neurodegeneration. Now, tremors means oscillatory movements, which means that the movement goes through or between an axis, like this. Okay, so imagine that the axis is here at the level of the wrist, so you have a up and down movement. That's a tremor. There are other type of movements, abnormal movements, such as a jerk. In medical terms, we call that myoclonus, which is unidirectional, one side up or down, but not like a tremor. That tremor is a rhythmic oscillatory movement. This is very important because the most important thing in movement disorder is to identify the phenomenology. So the phenomenology means if this is a tremor or a jerk or something else. Very important. Otherwise, you will get the incorrect diagnosis and then the incorrect treatment. For essential tremor, very important, you need to have hand tremors. Otherwise, you have something else. And the tremors is during action. So when you move, when you are trying to reach something, when you are eating, when you are writing, that's the tremor that you see in essential tremor. However, when you have essential tremor for many years, and it's very severe, approximately 20% of the patient, they might have a resting tremor. Okay? What is the importance of this topic? Well, because it is very common. If you see this article by Dr. Lewis, who is the neurologist that writes most about essential tremor in the literature, it is estimated based on this meta-analysis that the prevalence is close to 6% in patients over 65. And I personally believe that it's more than that, because many patients do not look for medical attention because they think that it's just a tremor, I'm getting old, everything is benign, which is not true at all. Just to put this in perspective, the other movement disorder that is more common is RLS, restless leg syndrome, and the prevalence is approximately 10% of the population. This might be overestimation since RLS is frequently misdiagnosed. Nevertheless, it's more common than essential tremor. The other reason number 2, is why this is important is because there is some evidence that some subset of patients with essential tremor develop Parkinson's disease after many years of having essential tremor. In other words, if you have essential tremor, you have 4 to 5 times more likely to develop Parkinson's disease than the general population. I personally have seen this. I have seen patients with essential tremor, with action tremor for many years, more than 25 years. And suddenly I start seeing that they start developing a resting tremor, for example, on the left hand, and some stiffness and some dexterity issues on the left hand. So those patients, they have a history of essential tremor, but now they are developing Parkinson's disease in addition to the essential tremor. The other reason why this is important is because the social isolation. Patients with essential tremor frequently feels embarrassed. The tremors might affect function significantly and can be actually heartbreaker in some instances. For example, I met a MS doctor, multiple sclerosis specialist. He's a neurologist specialized in neuroimmunology. And this doctor, when he started residency, he actually started as a neurosurgeon. So can you imagine being a surgeon and having essential tremor? So not a good idea, right? So he had to switch careers, and then he changed residency, and now he's an excellent MS doctor. So sometimes you have to switch things that you do in life because you have essential tremor. Can you imagine being a nurse and having essential tremor and trying to put a line? So it's not easy. That's my point. Now let's talk about what we can do about it, the most important part of this video. The first step is you need to be clear that a pill, a tablet, a capsule is not going to cure you. You need to be realistic. Not everything is solved by a pill. This is not a bacterial infection that you take an antibiotic for 10 days and goes away. This is a brain problem. And most likely we think it's a neurodegenerative disease. So it will progress. So you need to be realistic. The goal is not to stop the tremors. There is nothing that a doctor can offer you to stop the tremors. Decrease the amplitude of the tremor. And the medication that we have available decrease the tremor from 30% to 70%. And I have to be very clear that at least 1/3 of the patient cannot tolerate the medication at all. And actually close to 50% of the patients stop the medications because either they cannot tolerate the medication or the medication are not doing significantly nothing for them and they stop the medication. So you have to be very realistic. Now, the most important thing to do, in my opinion, to start is you need to make lifestyle changes. You need to improve the way that you eat, what you eat, and the amount of exercise, how much exercises you are doing. You need to push yourself a little bit. And this is not because any specific diet will improve the tremor or any specific exercise will improve the tremor. No, it's because you will feel better, your level of tolerance will improve, so maybe the tremors are not going to affect you too much. That's the idea. Now let's talk about the most important part of this video, which is the medications. The medication that we have available to treat essential tremor. So unfortunately, we don't have anything new. The only thing that we have is the same medication that we have for more than 10 years. For example, this is the guidelines that we have from American Academy of Neurology, 2011. So more than 10 years ago. Still using the same medication. Nothing new that I can prescribe at this time. But we'll go through all those medications we have available. Now, the first medication I will talk about is my first choice, which is Propranolol. Propranolol is a medication approved by FDA for many conditions, including high blood pressure, migraine headaches, and also for essential tremor. So for essential tremor, the doses that we use is you can start with 10 milligrams twice daily and increase by 10 every 5 days, every week. I typically divide the medication twice per day, sometimes 3 times a day, but you can use a long-acting medication. The lowest dose for the long-acting is 80 milligrams. Now, the most common side effect is low pulse, bradycardia, low heart rate. Okay, so if your heart rate is below 60, it's not a good idea to use this medication. Might need to use something else. If your heart rate decrease because you are taking this medication, then you will feel fatigue, you will feel dizzy, and the dizziness means that the perfusion to the brain has been decreased because your heart rate decreased, your blood pressure decreased, and you feel lightheadedness. Okay, so that's why you feel dizzy. And so if the heart rate is low enough, you can actually pass out. One other reason to use this medication is many times we have an overlapping between essential tremor and increased physiologic tremor. The physiologic tremor is the normal tremor. Everybody has some type of tremors. The only thing when we are anxious, or we are going to talk in public, or we are going to do something important, we shake, right? We put the hands like this and your hands will shake. So this medication, if you take 10 milligrams, sometimes 20 milligrams, 1 hour before your activity, you will be on a stage, you will be talking, you will be dancing or something, then that actually decrease the shakiness and even the shakiness of your voice too. So maybe remember that those medications that we use for essential tremor work better for the hands, the voice, and the head, not too much, except if this is associated with an enhanced physiologic tremor. Now, the next medication that we are going to talk is Primidone. So Primidone is the most potent one. The problem with Primidone is the side effects. So not every patient tolerates this medication. This medication has a lot of side effects, and that's why it's my second choice, but it's one of the most potent in terms of effectiveness. So if you ask me how much do you think you will improve in terms of the amplitude of the tremor if you use this medication, from 50 to 70%, 50 to 65%, depending which paper you read. But this is only if you reach good doses. And then you might ask, what do you mean with good doses? Well, that varies, but typically you don't go over 250, and we have data showing that doses over 250 per day, they are not better than 750. You only get more side effects. So I would say never increase the doses over 250 in any of my patients, because I personally have not seen anybody improving significantly with doses over 250, and we have actually some data to back me up. Now again, the side effects are a lot, and like I say, many patients cannot tolerate this medication. And actually, I don't know if I mentioned this before, but the majority of the patients, I would say probably 50% of the patients, stop these medications. Why? Because number one, they cannot tolerate, or the medication are not significantly affecting the level of function. So imagine that you have a tremor like this, right? And I'm telling you that I am going to decrease the tremor approximately 60% with this medication. So from here, you come here, right? So 50%, you decrease from here to here, still is a lot of tremor. So still you cannot eat. So it's not improving your quality of life. You still have tremors, significant amount of tremor. So if you are one of those that the tremors, the amplitude is significantly pronounced, then you need surgery. And when I talk about surgery, I'm talking about deep brain stimulation and MRI-guided ultrasound, that we will talk about that soon. Now, we talk about Primidone, we talk about Propranolol. Propranolol improves approximately 50% in the amplitude of the tremor. Primidone, around 60%, 65%, 70%, depending on which paper do you read. Now let's talk about the side effect of this medication. So the most common side effect of this medication, the one actually patients always tell you, is sleepiness, sedation, make you sleepy and make you dizzy. And the dizziness could be a dose-dependent side effect, but the same thing with the sedation too. So higher you go, more side effect you will get. Unsteadiness. So many patients. I have one lady who came a few years ago to my clinic, and she was taking 500 total dose of 500 milligrams of Primidone. And tremors seems to be pretty well controlled, but the unsteadiness, the dizziness, the vertigo, it was very difficult for her to describe the feeling, but she was very unsteady. Well, and what we did was decreasing the doses to 150, 150, 50, 50, and 50, and the tremors the same, and those side effects went away. So you have to be careful how high you go. So walking issues, nausea, blurry vision, and in high doses, this medication cause cognitive impairment and depression, because depress the central nervous system, right? So you will feel you are more predisposed to have depression. And actually, there are some papers that state that depression is very common in patients with Primidone. Approximately 40% of the patient develop depression on this medication. So you have to be careful on those if you are predisposed to have depression. And again, higher the doses, more side effect, especially cognitive impairment and depression. Now, the other medication that we need to talk is Topiramate. So this medication is less effective, approximately 30% improvement in the amplitude of the tremor at therapeutic doses. And when I say therapeutic doses, usually around 100 milligrams twice daily, more or less. This is the doses that they use on trials. So, but good luck getting to these doses if you are 65 years old, okay? Because people over 65, rarely, I haven't seen any patient tolerating 100 milligrams twice daily over 65. And I see tremors all day long. So one thing is that this is the doses they use on trials, but in real life is different. Real life is totally different. So the side effect of this medication is feeling slow mentally. Those patients feel slow mentally. And also word finding difficulty. It's very hard for them to spread themselves. They have the word, but it's not coming out. I'm very frustrated for them. And what you have to do if you have this word finding difficulty is decreasing the doses. That's the first thing to do. Never stop this medication cold turkey, okay? Never, any of them, never. Other common side effect, especially initially, is the tingling sensation. We call that paresthesia, usually face or fingers. Usually goes away by itself, but not always. And sometimes we need to stop the medication. Never stop, taper down. Weight loss is a common, I don't want to say side effect, but could be an effect. And for many people could be a good effect, right? So because decreased appetite. How that happen? I don't know. Nobody knows. Decrease or affect the taste. And actually, that might be one of the reasons why you have a decrease in the appetite, because the food doesn't taste the same way. Also, dizziness. All these medication might cause dizziness, okay? All of them. And fatigue. All of them might cause fatigue as well. You feel tired, fatigue. And now, if you have history of calcium phosphate kidney stones, this is not a good choice for you, okay? This is approximately 10% of the kidney stones are this type of stone with calcium phosphate. So if you have this type of stones, and the only way to know is if you have the stone and you can collect the stone and you give it to the urologist, so they can examine the stone and they can tell you what type of stone do you have. The calcium oxalate is the most common one, which is 70% of the kidney stones. Topiramate is not going to make more likely you to have the most common type of kidney stone, which is calcium oxalate. Is the calcium phosphate. Okay. Now, in terms of the doses, you can start with a low dose of 25 milligrams. So we have a tablet of 25. You can use a 25, and if you cannot tolerate that because you have one of those side effects, especially the fatigue and the sleepiness, then you might need to go even lower, which is 12.5. The same thing applies with Primidone. So if Primidone comes in 50 and 250 milligrams, so you cannot tolerate half of the tablet of the Primidone, then take half of the half. Start with that and go up by a week or even every 2 weeks. You have to go slow on those medications, okay? If you want to tolerate, because the key here is if you are able to tolerate therapeutic doses in these 3 medications, especially the Topiramate and the Primidone, which they have more side effect than Propranolol, and that's why Propranolol is the first choice. One thing I forgot about Propranolol, and going back to Propranolol, is like if you have asthma or by any chance you are using albuterol, which is the pump, not a good idea to use Propranolol, because Propranolol will cause the opposite effect, so it will cause bronchoconstriction. So it doesn't make sense if you are using the pump, albuterol pump, right? So you have asthma, you should not be using Propranolol because it will cause you to have wheezing. And you have COPD, so you have to be careful. So COPD, the fact that you have COPD is not a contraindication to use beta blockers. It's not contraindicated. But if you are using albuterol every day, then doesn't make sense, right? Doesn't make sense. Then the other medication less effective that I never use for essential tremor, even though the American Academy of Neurology give gabapentin, alprazolam level B of evidence, and clonazepam, I think level C, is gabapentin and alprazolam. I don't use those medications. Number one, gabapentin, I haven't seen any patient telling me that after reaching doses of 600 milligrams 3 times a day, which is the therapeutic dose that they use on trials, have some benefits. I haven't seen that. So I don't prescribe that for essential tremor. I have not seen any patient telling me that this medication is helping them for anything. Now, alprazolam, yes, alprazolam help, but for a short period of time. So I try to avoid, actually I don't use alprazolam at all. If I have a patient on alprazolam, because they were taking alprazolam prescribed by another provider, but the problem with this medication is that you get used to, so the receptors, GABA receptor, get used to, and then you need more and more and more. So the effectiveness is not going to be the same as last year, and then you need a little bit more, and then at the end you will become addicted to this medication. And then the problem is when you start those medications, it's very difficult to stop those medications, especially the Xanax, because it's short acting. So clonazepam is a long-acting medication. So I have a lot of patients on clonazepam, not because they have tremors. I don't use it for tremors. I use it for other things, such as REM sleep behavior disorder. But if they have action tremors, okay, so that's another reason. But not because you have tremors, I would put you on benzodiazepine. For me, it's not an indication. Even though the American Academy of Neurology, they put them level B and for alprazolam and level C for clonazepam, as I mentioned before. Not a medication that I like, any of them. It's a gabapentin, but not for tremors. I use gabapentin for other things. And one of the things I have to tell you about gabapentin, you have to be careful if you have renal failure. Why? Because gabapentin is eliminated by the kidney, and if for whatever reason you are in the hospital, you become dehydrated, and you start not acting right and having not tremors now, jerks, that means that you have toxicity of gabapentin, because probably you have renal failure, it get accumulated, and this is how the brain works. So So basically you will be confused, you will be sleepy, you will be jerking, and then the doctor realized that you are taking gabapentin. The creatinine and the renal function are worse, so they need to decrease the doses, to adjust the doses based on your renal function. Very important. Now, this is something that we need to update the guidelines. By obviously these guidelines are from 2011, so many years ago, right? But botulinum toxin, if you inject correctly, it works very well. The only thing is it works maybe one shot that you do, right? And then the next one, because it's hard to inject in the same spot, in the same place. So maybe it doesn't work like in the prior section. So it's tricky, but it's a good choice because it's very safe. The only thing that can happen if I pass the line is I might cause weakness of the grip, right? So the muscle to inject are the flexors. So if you have a tremor that only have one axis, right? One axis. So if you are shaking like this to all the direction, because there are some patients that they have kind of difficult tremors, and they still have essential tremor. The only thing is it can be mixed with other things, or sometimes the essential tremor is not too rhythmic, right? But if you have a one axis, so flexion and extension, pure flexion and extension, that I have seen that, and you don't have too much fat. You don't have too much fat, so I can palpate very well the flexor, the flexors of the wrist, right? And I can palpate very well. I can inject very, very well on those muscles, 10 units, 15 units, sometimes 25 units, and work very well. Okay, very well. One day, I will try to get a video of a patient pre and post, and you will see what I'm talking about. So, and it's not just that looks better. Actually, I have seen the function getting better. When I say the function, I mean the writing and the drinking. Okay, and sometimes, because every patient is different, you need to inject other muscle, not just the wrist. Some patients actually have a lot of tremors in the bicep, so you need to inject the bicep as well. You have to be careful with the injection of the extensors. The extensor here. Why? Because for whatever reason, I don't understand well, they are more sensitive to weakness. Maybe because they have the extensors muscle, they have more cortical representation, maybe, and that's why they are more sensitive. So if I inject, the doses that you use for the flexor are not the same that we use for the extensors, because the extensor, they are more sensitive, and you will cause more weakness. So the first injection, we always try to only inject the flexor, and then we go over. We might inject the extensor, but a tiny dose, maybe 5 unit, 2.5, that kind of things. Okay, you have to be careful, and very important that don't give up. Give the doctor another shot and maybe another one. Okay, 3 before telling the doctor it's enough. Okay, why? Because rarely work with the first shot. You need to give the injector, the doctor, time to adjust doses and muscle selection, because like I say, you might need to add other muscles during the next cycle. And the Botox, when I say Botox, I say Botox, but I should not say Botox, because there are Botox, Xeomin, Dysport, and there is another long-acting medication. I would not recommend the long-acting medication that we have, because if you cause weakness, it will last longer. So for these kind of things of tremors, you better use Botox, Xeomin, or Dysport, not the long-acting. Okay, so let me see what I have more here. So this is another thing that apparently the medical insurance are covering. So you read these things on the website. You can go to the website and you see that covered by Medicare. Yeah, it might cover, but doesn't mean that you are not going to pay anything out of pocket. Okay, so when the company big farms is telling you that that is gonna get covered by the insurance, yeah, you're gonna get covered, but you still can pay a lot of money out of pocket. Okay, I have seen many times patients getting expensive medication. I'm not going to talk about which medication, but expensive medications that we use for Parkinson, and is covered by the insurance, but then when they go to the pharmacy, the co-payment is $600 per month. You see what I'm talking about? So it get covered, but out of pocket still is a lot of money. Okay, so the best thing that you can do is go to this website. Okay, Kala. The name of this is Kala, K-I-Q, and this is basically a watch. It's like a watch device that stimulates two nerves here, the median nerve and the radial nerve. And then those signals of the stimulation, when you stimulate for 40 minutes, those signals travel to the brain and disrupt the abnormal tremor circuit that you have, right? So, and the effect might last a little bit more than 60 minutes. And after having a 40-minute section. So you use the watch and then you do whatever you need to do. So like going to a restaurant or drinking your coffee, but it's just on demand, basically on demand. So you use it and then you will be good or significantly better. I don't want to say that the tremor will go away, but significantly better for approximately 60 minutes. And then you have what we call deep brain stimulation. So let me be very clear here. So if you have severe tremor like this, right? Those medications that I talked before, they're not going to touch you. Okay, I'm telling you, you can try, but they are not going to touch you. It's not going to improve your quality of life at all, because you still will have tremors, significant tremors. So remember I told you that the tremors decrease 50-60%. So imagine that you have this type of tremor, right? Like you see these patients. So with the medication you decrease 50%, still like this. So you are not going to be able to eat, you are not going to be able to drink, so you need surgery. Okay, and we had two type of surgery, two type of procedure. One of them they open the head, and the other one they don't open the head, but they literally burn the area of the brain that we call the thalamus. So we'll talk about that soon. Let's talk about deep brain stimulation first, which is the one I know the more, because I have plenty of patients with deep brain stimulation. These two are my patients, and I have many like them, but I have this is one of the most severe cases. Let me show you this.
Okay, put your hands up.
So this is a patient with essential tremor.
Your chin with the right, back and forth. Keep doing it like this. The other one. Oh,
you see, very severe tremor, very severe tremor. So let me stop here. Oops. So I turn on the deep brain stimulation, and then I told him to put the hands down, and you see what happened now. In seconds, 3 seconds, he's on.
Better?
Yeah.
Look at this.
Don't take it like a leaf in a tornado to nothing.
Like a
Put your
tornado.
hands up.
And look at this. Look at the tremor.
Okay, now and then the other one.
You see that?
Ah, that's great.
It's amazing. Okay.
Okay,
Now
put your
let's see this one. So it's on now,
Let's see what happened.
and I will turn this off, and you will see the tremor. I turn it off. You see? And I'm telling her now to lift the left arm,
Can you leave the left arm?
and look at this. It's worse, right? Because it's action tremor. Very bad. Very bad.
Let me turn this on.
I turn it on, and then in seconds,
A lot better. Right?
Lots better.
oh, better. You see that? It's amazing how that works. And then you have what we call the magnetic MR guided focus ultrasound. which I have probably no more than 3 patients, and the thing is that I don't follow those patients. One patient I got this procedure came back, and I was impressed. With the benefits. It was not 100%, but I would say 90% improvement. 90% improvement, pretty good. He got in one side. He was right-handed, and he got this procedure on the left. Because remember, the left side controlled the right side. So, and significant improvement. And I saw him after 1 year and still the same improvement. And no major side effect. He told me that he was having some tingling sensation after the surgery in the face that lasted a few days and then went away. But otherwise, nothing else. So he's doing fine. Now I have another patient that got this procedure for tremor, predominant Parkinson's disease, and helped for a week only, and then it didn't help anymore. So, and that patient ended up having deep brain stimulation with significant improvement. So, you know, I don't have too much experience with this procedure. The best way for you is just to go to this website that you see here and get information. There are many hospitals and places that they can do this. But it's a choice, and nobody open your head. But still, they are literally burning, high intensity ultrasound to a specific area of the brain. That is the same area that actually we stimulate with deep brain stimulation. It's the thalamus. We call that BIM. So the only thing is that you have more side effect from the ataxia and the paresthesia, tingling, numbness sensation post surgery. Typically, based on data, it's transient, goes away, but there are some patients that they still have the issue with this, with ataxia and the numbness. So anyway, it's a choice. It's a choice, but if I have severe tremor, I would probably get a deep brain stimulation, but I can be wrong. You know, things might change, and maybe technology has been improving significantly. That the MRI guided ultrasound might be the best thing. Maybe during the next 10 years, I don't know. We'll see what happens. So that's it. That's the only thing I have for you guys today. So if you like this video, don't forget to subscribe to my channel. See you soon.